Okay, good evening, everyone. Let's go through the topic of today, that is managing hyponatremia in the ER. So as with every week's webinar, we have one of the eminent speakers today, Dr. Mehul Gajjar. He's an MD, General Medicine, then Associate Professor. As of now, he's working as Associate Professor at Emergency Medical Medicine Department at N.H.L.Municipal Medical College. So he has done his PG and UG both from N.H.L. Medical College and currently working there itself. So he's the faculty of India's first MCI approved MD Emergency Medicine course. He has about 14 years of teaching experience in emergency medicine. He is a faculty for BLS, ACLS, and FCCS courses. And he has been part of several publications, that is national and international. So even lectures in various national and international scientific conferences in the field of emergency medicine and critical care. It's good to have you on the webinar platform, Doctor. So please go ahead with your talk.
Good evening, all dear senior colleagues and my fellow fraternity and faculty from emergency medicine fraternity. Today's my talk is about management of hyponatremia. The objective of my talk would be a brief introduction to hyponatremia, about epidemiology of hyponatremia, pathophysiology, etiology, clinical features, diagnostic evaluation, and treatment of hyponatremia. As we all know, hyponatremia is defined as serum sodium level less than 135 milligrams per liter. It is the most common body fluid and electrolyte disorder encountered in clinical practice. Now, coming to prevalence of hyponatremia, this one is one of the largest study about electrolyte disturbances, which analyzed almost more than 3 lakh samples from more than 1.2 lakh patients, which revealed that hyponatremia is present in almost 28.2% of acute hospital care admission, 21% of ambulatory hospital care admission, and almost 7.2% of the patient of community care hospital. So prevalence of hyponatremia is very high. Prevalence of hyponatremia in hospitalized patients with heart failure or cirrhosis is around 28% and 24%, according to this study by Rossi JLC in 2007. So prevalence of hyponatremia as such is very high in hospitalized patients. When it comes to incidence, these are several studies which shows the incidence of hyponatremia. All of these studies demonstrates that incidence of hyponatremia in admitted patients varies from around 2% to almost 48%, but on an average 22 to 25% of the patients have hyponatremia when they are admitted initially. Coming to serious part, that hyponatremia is quite a few times associated with mortality. These are various studies which shows the correlation between sodium level and mortality. And most of these studies show that whenever there is a serum sodium level which is less than 125 milligrams per liter, there is mortality rate of around 20 to 25%. Some studies mention that the rate is very high, like 51% or 45%, like studies done by Catil and Erasmus et al. But on an average, around the mortality rate in severe hypernatremia is around 20 to 25%, which is demonstrated by the studies. So hyponatremia is not only commonly prevalent, but it is also a serious issue. Now, coming to mortality due to brain swelling in case of hyponatremia. Now, this is one interesting study which was done in Cleveland Hospital. It showed that whenever hyponatremia developed acutely, that is less than 48 hours, the mortality is very high. It's almost 50%. While in case of chronic hyponatremia, whether symptomatic or asymptomatic, mortality rate is not that much high. Only it is a little bit higher in case of chronic symptomatic hyponatremia. But here in this study, the level was serum sodium level was around 115 milligram per liter. That is also one kind of serious hyponatremia. Coming to subgroup of patient, this one study showed that hyponatremia has very high mortality in case of pulmonary disorder like pulmonary tuberculosis, which shows that mortality is around 50%. In heart failure, the mortality is around 35%. And in case of myocardial infarction, mortality is around 20%. So it is associated with very high mortalities. Coming to pathophysiology of hyponatremia. Previously, it was thought that hyponatremia is a problem of sodium, but now there is new approach called as Alderman approach. It's clearly demonstrated in 2005 that hyponatremia is not only the problem of sodium, but it is a mixed problem. It is a problem of sodium as well as H2O. So whenever there is imbalance between sodium and H2O, there is hyponatremia. Most of the time, there is relative excess of body water as compared to total body sodium and potassium, which leads to hyponatremia. And most of the time, it is usually associated with a disturbance in secretion of a hormone called as antidiuretic hormone. Coming to total distribution of body fluids, we all know that in a male patient, it's around 60% of the body mass is fluids, while in case of female, it's around 55%. And out of this, 2/3 is intracellular fluid and 1/3 is extracellular fluid. Again, this extracellular fluid, only 20% is plasma, while 80% is interstitial fluid. So when we are seeing serum sodium, it shows only a portion of whole serum sodium distribution. Coming to water intake and output, on an average, healthy person, it takes around 2.5 liter of water as an intake, out of which most of the time 60% is from beverages, 30% is from food, and 10% is generated by internal metabolism. Coming to the exit route or output of water, urine is the predominant source. Around 1.5 liter of water is excreted in urine, that is 60%. Another 40% is excreted via skin, insensible loss, sweat, and feces. But out of all of this, only urinary part can be controlled. All others cannot be controlled. So that's what body targets whenever there is water disturbances are there. Coming to water reabsorption, most of the time water is reabsorbed passively from proximal converted electric tubules and thin part of the ascending loop of Henle after the solute absorption. The 65% of water is passively absorbed, while another 30-35% of the water is absorbed under the influence of antidiuretic hormone from the distal converted tubules and collecting ducts. So only controllable part of water reabsorption is under antidiuretic hormone. Whenever there is a disturbances in homeostasis and ECF volume is disturbed, whenever there is a decrease in the ECF volume, which leads to decrease in the blood volume and decrease in the blood pressure, the renin-angiotensin system as well as ADH release is stimulated. So whenever there is aldosterone release, there is a increased urinary sodium retention, while ADH release, it causes decreased urinary water loss as well as it increases thirst, which re-establishes the normal ECF volume. Whenever ECF volume is increased either by fluid gain or fluid plus sodium gain, which leads to blood volume and arterial distension, which leads to release of natriuretic peptides, which causes release of aldosterone, which decreases the release of aldosterone and antidiuretic hormone, which decreases the thirst, decreases the urinary water loss, and also increases the urinary sodium loss, which ultimately leads to normal ECF volume. Coming to sodium metabolism, out of 120 millimole sodium that is consumed, only 5 to 10 millimole sodium per day is excreted in feces. All other is reabsorbed in extracellular fluid. The sodium in extracellular fluid again Out of these, almost 2.2500 millimoles, only 10 to 15 millimoles is excreted in wheat glands. And another 2450 millimoles, they are filtered in kidneys, and only 10 millimoles of sodium is lost in urine. So basically, there are three output which can be there for sodium concentration maintenance. And again, in our this also urinary part is only under the hormonal control, because sweet glands and feces sodium excretion is not under the control of homeostasis. Almost 67% of this sodium is absorbed in proximal convoluted tubules, and 25% is absorbed in thick ascending loop of Henle, and 5 almost 8% is absorbed in distal convoluted tubules and collecting ducts. Only less than 1% sodium is excreted. So ultimately there are three primary regulatory hormones: antidiuretic hormones, which stimulates the water conservation and thirst centers; aldosterone, which controls the sodium absorption and potassium loss; and natriuretic peptide like ATL and brain natriuretic peptide, which reduces the thirst and blocks the release of ADH and aldosterone. So out of this, for water metabolism and sodium maintenance, ADH is the most important hormone. It's secreted by supraoptic nucleus of posterior pituitary gland. The stimuli for release of antidiuretic hormone, the predominant stimulus is serum osmolarity. Whenever there is 1 to 3%, even 1 to 3% of decrease in the serum osmolarity leads to secretion of antidiuretic hormone. 10 to 15, as low as 10 to 15% decrease in circulatory volume or blood pressure also leads to secretion of antidiuretic hormone. But several other non-specific stimuli like pain, nausea, stress, and several drugs can also cause release of antidiuretic hormone. Now, these factors are also important in case of post-operative patient and some medication which can lead to secretion of antidiuretic hormones, and which ultimately can lead to syndrome of inappropriate antidiuretic hormone secretion or post-operative hyponatremia. The antidiuretic hormone basically acts on the V2 receptor of distal convoluted tubules and collecting ducts, and it facilitates the reabsorption of water by aquaporin 2 channels. Coming to classification of hyponatremia, the classification of there are various classification of hyponatremia. First depends on the serum sodium concentration. That is mild, moderate, and severe hyponatremia. The levels between 130 to 135 is called as mild. 125 to 129 is called as moderate, and less than 125 is called as severe hyponatremia. But limitation of this clinical utility is the symptom does not always correlate with degree of hyponatremia. Depending upon the time of development of hyponatremia, the cutoff value is 48 hours. Whenever the hyponatremia develops less than 40 hours, it is called as acute hyponatremia. And whenever it develops within more than 48 hours, it is called as chronic hyponatremia. But exact time of development of hyponatremia most of the time cannot be always predicted. The next classification is symptomatic versus asymptomatic hyponatremia, which depends on the presence of the symptoms. Then again, depending upon the serum osmolarity level, hyponatremia can be classified as hypotonic, isotonic, or hypertonic hyponatremia. But serum osmolarity does not consider ineffective osmoles like urea, ETOH, alcohol. These are the ineffective osmoles which cannot be calculated in case of serum osmolarity level. So this is a pitfall of classification that is based on serum osmolarity level. The last one is on the volume status. That is hypovolemic, euvolemic, or hypervolemic hyponatremia. But clinical assessment of volume status is, has also low sensitivity and low specificity. So these are various classification systems for hyponatremia. Coming to clinical features. Clinical features depend always on the severity of hyponatremia and the rate at which hyponatremia is developed, how fast hyponatremia is developed. Usually, whenever there is a hyponatremia, Because of change in the osmolarity, uh, because of low osmolarity, there is water gain. That is, water is comes to the intercellular level, which leads to brain edema. Due to this, there is a rapid adaptation system which causes loss of sodium, potassium, and chloride from the cell, which leads to outward movement from the cell, water from the cells. This gradually leads to, after depletion of and saturation of the sodium potassium pumps, this leads to a slow adaptation called as organic osmolyte adaptation, in which the brain causes loss of organic osmolytes, which ultimately reestablishes the brain volume and decreases the edema. This stage is sat at the level of after 48 hours, and this is why this is called as chronic hyponatremia. If proper therapy is given, the brain volume can be established. But if therapy is not proper and there is a rapid correction of this hypotonic state, there can be a dreaded complication called as osmotic demyelination. So always, whenever there is a chronic hyponatremia, don't correct the hyponatremia very fast. Gradual correction is always recommended. Now, whenever there is acute hyponatremia, say hyponatremia that develops within 48 hours, there is initial transit of water and ions from the extracellular to intracellular compartment, which leads to brain swelling and severe neurological symptoms. Because there is no rapid adaptation, brain cannot quickly and completely adapt to a rapid decline in the osmolality and change in the serum sodium, which leads to severe neurological symptoms like seizure, coma, which can also progress to brain herniation and death. These symptoms always correlate with the level of the serum sodium level. That is how fast the sodium has declined. So whenever the sodium is less than 120, the severe symptoms are associated with serum sodium level that is less than 120. That is beautifully established and explained in this study by Arif et al., which clearly tells that any serum sodium level less than 120 is associated with stupor, coma, seizure, and dreaded complications. The signs and symptoms of acute hyponatremia also correlate with serum sodium level. Whenever the serum sodium is less than 120, there is headache, restlessness, lethargy, seizures, brainstem herniation, respiratory arrest, and death. These are severe symptoms. While serum sodium level between 120 to 130 leads to moderate symptoms like malaise, unsteadiness, headache, nausea, vomiting, fatigue, confusion, muscle cramps. And the levels between 130 to 135 and quite a few times asymptomatic or only mild symptoms like headache, nausea, vomiting, confusion, muscle cramps, and depressed reflexes. The symptom of acute hyponatremia can also be remembered by a small mnemonic called as SALT loss, which stands for stupor or coma. A stands for anorexia, L stands for lethargy, P stands for tendon reflexes, L stands for limping of muscle or weakness, O stands for orthostatic hypotension, S stands for seizure or headache, and S stands for stomach cramping. So this is a small mnemonic for remembering symptom of hyponatremia. Well, in case of chronic hyponatremia or hyponatremia that has developed for more than 48 hours, the brain loses organic osmolytes and there is chronic adaptation. So slowly and slowly brain adapts and there is reduction in the brain swelling. But always remember that there is always a low osmolarity in brain that persists even after normalization of brain volume, which can lead to mild or subtle symptoms even after complete brain adaptation. Coming to diagnostic approach, the first step in case of hyponatremia is to always make sure that it is a true hyponatremia. Always recheck the sodium level and make sure that there is no margin for error or any laboratory error. Once you have confirmed that the levels are right, the next step is always exclude the drugs. There are n number of very large number of drugs inter which can change the sodium level by various mechanisms. Uh, like affecting the sodium and water homeostasis, affecting only water homeostasis, or potentiating ADH effect, or causing resetting of osmosis. But out of all of this long list of drugs, most important drugs that are important is thiazide, amyloids, loop diuretic, tricyclic antidepressant, carbamazepine, oxcarbamazepine, valproate, because these are very common drugs that are used. Uh, so these are important cause of, and these are the drugs which are used in case of CNS disorder or patients who are metabolically unstable. So at that time, there are high chances that this may cause hyponatremia. So always exclude the drugs as a cause of hyponatremia. So once you have excluded the drugs and the serum sodium level is correct, the next step is you determine whether it is true hyponatremia or pseudo hyponatremia. So what is the difference between true hyponatremia and pseudo hyponatremia? So sometimes we all know that there is a translocational hyponatremia. So whenever there is a high osmolarity, as such in case of very high glucose level, or whenever hypertonic solutions are given, there are translocational hyponatremia. And second is pseudo hyponatremia, that is hyponatremia that is in case of normal osmolarity, that occurs in case of hyperlipidemia and hyperproteinemia. So once we have ruled out, then it is called as true hyponatremia. In case of hyperosmolar hyponatremia, always remember that there is a formula of plasma osmolarity, that is 2 into sodium plus glucose by 18 plus blood urea by 2.8. So whenever by default glucose increases, the sodium decreases. And that is established in this beautiful paper, which clearly tells that there is inverse correlation between sodium level and glucose level. With each 100 milligram rise in the glucose level above 100 milligram, there is a decrease in the serum sodium level by 1.6 milligram per liter. Other agent which causes hyperosmolarity and hyponatremia are mannitol, glycerol, and maltose. Second is isoosmolar hyponatremia. The higher level of lipids and protein can interfere by displacing water and causing a measurement error. So always rule out that there is no isoosmolar hyponatremia also. So once we have ruled out the pseudo hyponatremia, uh, then it's called as true hyponatremia or hypotonic hyponatremia. Now, once there is a true hyponatremia, you have to look out for the causes of hyponatremia. Most of the time, causes of hypotonic hyponatremia is either dilution from retained water, that is sodium or potassium is lost as normal base, but water is getting retained, which causes hyponatremia. Or there is a depletion in the electrolyte, that is sodium is lost more as compared to water. So which can so there is either dilutional hypotonic hyponatremia, or there is a depletional hypotonic hyponatremia. So once you have established that there is a hypotonic hyponatremia, next step is you have to check for volume status of the patient, whether it is hypovolemic hyponatremia, euvolemic hyponatremia, or hypervolemic hyponatremia. The hypervolemic hyponatremia occurs in cases of heart failure or cirrhosis or nephrotic syndrome or advanced chronic renal diseases, when because of homeostatic mechanism, there is excessive fluid and excessive water as compared to sodium, which leads to the hyponatremia. The second is hypovolemic hyponatremia. So hypovolemic hyponatremia means there is loss of volume. Now this volume can be lost either through the kidney or extra renal loss. So in case of renal loss, there is loss of renal concentrating abilities. So because of that, the urinary sodium level will be more than 20 millimole per liter. The cause is diuretics, mineralocorticoid deficiency, cerebral salt wasting syndrome, uh, salt losing nephropathy. The extrarenal causes are diarrhea, vomiting, or exercise induced. Here, the concentrating mechanism of kidney are intact. So urinary sodium would be less than 10 millimole per liter. Coming to euvolemic hyponatremia, in case of euvolemic hyponatremia, The most common cause is syndrome of inappropriate antidiuretic hormone secretion, where there is excessive ADH is secreted. The ADH secretion can be stimulated by various cancers, particularly small cell carcinoma of lung or various drugs. Uh, all of this can lead to SIADH. Second is hypothyroid state and adrenal insufficiency can also cause euvolemic hyponatremia. Uh, Hospital-acquired post-op hyponatremia can also be a euvolemic. Here, because of pain or other stimulus, there is a secretion of ADH hormone. And the last rare causes are beer protomania, and T-Toes syndrome. Here, as the person is either alcoholic or taking a lot of solid in form of beer or carbs, this leads to euvolemic hyponatremia. So this is the diagnostic approach for hyponatremia. Now coming to the treatment part. The treatment part depends on whether hyponatremia is developed acutely or chronically. The hyponatremia is symptomatic or non-symptomatic. What are the risk factors for neurological complication if there is a correction of sodium level? So always you should look for risk-benefit ratio. In case of acute hyponatremia, the risk of symptoms due to hyponatremia is more as compared to risk of correction. So at that time, aggressive correction with hypertonic saline or 3% NaCS is recommended. While in case of chronic asymptomatic hyponatremia, the risk of hyponatremia is due to symptoms are less than risk of correction of by hypertonic saline. So here you should always consider that there are higher chances of brain edema or osmotic demyelination if you do a rapid correction. In case of chronic symptomatic hyponatremia, there is some brain edema, but partial brain volume regulation is also there. So here you have to take individual decision. The principles of treatment is serum sodium always depend on the extracellular sodium plus potassium and inversely depend on the total body water. So you can always add to numerator if you want to improve sodium, or you can always subtract from the denominator. That is, you causes fluid restriction or loss of pure water from the body, which improves the serum sodium level. This is the principle of treatment. The monitoring. Various guidelines they recommend that strict input and output chart of the patient, strict measurement of volume status of the patient, as well as strict daily weight if patient is hospitalized. Frequent sodium and potassium monitoring. The European and American guidelines they recommend sodium monitoring every 2 hourly. I don't know how it's possible in our scenario, but guidelines they do recommend 2 hourly sodium monitoring of plasma osmolarity daily, and urinary osmolarity, urinary sodium and potassium for the diagnosis of hyponatremia. Now coming to management algorithm, first you have to decide whether the patient is symptomatic or not. If patient is symptomatic, then what is the level of symptom, whether there are severe symptoms or moderate symptoms. If patient is asymptomatic, then whether it is acute hyponatremia or chronic hyponatremia. If there is chronic hyponatremia, you have to rule out circulatory overload is there or circulatory overload is not there. If circulatory volume is not reduced, then you have to see whether ECF volume is expanded or ECF volume is not expanded. So this is the flowchart of management algorithm for hyponatremia. If patient is symptomatic, the symptoms are severe like seizure, coma, cardiorespiratory compromise, or low deteriorating GCS. At that time, you have to act fast and you have to correct the sodium level very fast. So here you have to correct the sodium level with 3% saline. You have to correct up to the maximum correction limit, that is 10 millimole per liter of correction. Suppose if sodium level is 105 or 105, you have to correct at least up to 115 millimole per liter in first 24 hours, or correct till symptoms improve. Like if you are given a bolus of sodium 3% NS and symptoms have improved, you have to correct up to that limit. The safe limit, like if you have achieved the serum sodium level of 130 millimole per liter, then you have to stop the 3% saline. There is a formula called as Andromedia's formula that determines the change in the serum sodium. The change in the serum sodium is equal to infused sodium minus serum sodium upon total body water plus 1. The infused sodium is 3% saline. That contains the sodium level of 513 millimole per liter. Right. So this formula is important. Now you have to also determine the total body water. The total body water in case of man less than 70 years and is 0.6 into body weight. In case of man more than 70 and woman less than 70, the correction factor is 0.5 into body weight. In case of woman more than 70, correction factor is 0.45 into body weight. So if then you exactly calculate this much body water in liters are there. So I want correction, the correction factor that is roughly around 10 is multiplied to that liter. And suppose if there is a male who has a weight of 60 and body water, the age is 45. The total body water would be 3.6 liter. Now for 3.6 liter, and if you want to correct serum sodium level by 10, it would be around 600. So it will require at least 600 milligram per liter. So you gradually correct that. Now coming to managing severe symptoms. So always, whenever there is an impending severe symptoms like coma is there, deceleration is there, deceleration is there, GCS is deteriorating, respiration is deteriorating. In this kind of condition, always you recheck the sodium level and give a bolus of the 3% saline. The bolus dose is 150 ml or roughly around 2 ml per kg. You can repeat the bolus twice or up to the improvement of the symptoms. If there is no improvement of symptoms after 3 boluses, then you correct the sodium level according to the general rules of raising serum sodium. That you calculate the deficit and then start it according to that infusion. Now, the American and European guideline, they differ here. The American guideline, they recommend that 3 boluses of 100 ml of 3% saline. While in case of European guideline, they recommend 150 ml, 3% saline, maximum twice. Ultimately, both are recommending 300 ml of saline, but there is a slight difference here in both of the guidelines. Now coming to the moderate symptomatic hyponatremia. Here the symptoms are like encephalopathy, headache, confusion, nausea, vomiting. These are the signs and symptoms of moderate symptomatic hyponatremia. Here the guidelines, they recommend that you should at least give 1 dose of 150 ml 3% hypotonic saline and see whether symptoms are improved or not. If symptoms have clearly improved and patient the consciousness is quite improved, then you should have to stop the infusion. If there is no improvement in the symptoms, then continue the infusion targeting general rules of raising serum sodium level. Now coming to the interesting part, that is a patient is asymptomatic and have acute onset, acute fall in sodium level. The patient does not have symptoms, but his serum sodium level at fall is in say 115 or 112. So in this kind of patient, what to do, whether we have to correct aggressively or not. Coming to guidelines, both American and European guidelines, they all insist that if there is a severe hyponatremia, the patient is an acutely developed severe hyponatremia, like serum sodium level that is less than 120, and the patient is asymptomatic, but that has developed within say 48 hours, and you have to correct the hyponatremia. Why you have to correct is because patient is not suffering from clinically significant brain edema. Adaptation is going on, but adaptation is not complete, right? So always there is some chances that brain edema is there and it may worsen. So here, the guidelines they recommend that you have to give 150 ml of 3% hypertonic saline 2 ml per kg, uh, and make sure that you activate the diagnostic pathway, rule out the drugs, and serum sodium level is right. The second is the chronic hyponatremia, where patient is asymptomatic. Here you have to assess whether circulatory volume is reduced or not. If circulatory volume is reduced, that is hypovolemia, and there is chronic hyponatremia and there are no symptoms, you have to correct with 0.9% saline or 0.9 NS. The dose is 0.5 to 1 ml per kg per hour and maintain general rules of correction of serum sodium level. This is the only condition where 0.9% is recommended, 0.9% NS is recommended in treatment of hyponatremia. All other conditions, 0.9% is not recommended. Coming to chronic asymptomatic hyponatremia, where circulatory volume is not reduced. Then again, you have to see whether circulatory ECF volume is expanded or not expanded. If ECF volume is not expanded, right, this clearly indicates that this is a case of SIADH. Here you have to do a fluid restriction. You have to supplement oral NaCl or oral salt supplementation around 8 to 10 grams per day. You can also use AVP antagonist, that is various kind of Vaptans that is available. The commonly available Vaptan is Tolvaptan, that is the dose is 30 milligram on the day 1 and 50 milligram or 10 milligram per day thereafter. You can also try this low dose loop diuretic here also. One more thing is that there is a difference between American guideline and European guideline. The European guidelines, it clearly does not recommend AVP antagonists in case of SIADO. Well, American guidelines, they do recommend the second line therapy after fluid restriction. In case of ECF volume expansion, clearly this is a fluid overload or what we call as water overload. So you have to do a fluid restriction, or you can always remove the excess of water by AVP antagonist or Vaptans. But again, European guideline here also does not go for recommendation of Vaptan. The reason they tell that there is no mortality benefit or no overall symptomatic improvement if Vaptan is given or not. While American guideline, they clearly recommend Vaptan as a second line therapy in case of chronic asymptomatic hyponatremia where circulatory volume is not reduced. Coming to fluid restriction, there are clear guidelines for fluid restriction. You have to go for a urinary sodium plus urinary potassium upon plasma sodium level. Now, if this factor is more than 1, the recommended water intake is less than 500 ml per day. If this factor is less than 1, the fluid intake is recommended for 1 liter per day, and if it is exactly 1, then it is 500 to 700 ml per day. So that much fluid restriction is important. Only problem with fluid restriction is that it raises the serum sodium level in a very tidy space, at a tidy pace. Hardly say it will raise 1 or 2 millipoints per week. But still, it is the first line therapy in case of chronic hyponatremia, because here you don't require any medical thing or whether there are no severe or acute symptoms. So here fluid restriction works. Now, something called as osmotic demyelination syndrome, which is rare but dramatic complication of hyponatremia. This syndrome was previously known as central pontine myelolysis, but later on it was recognized that not only pons, the other sites can also be involved. So the name was changed from central pontine myelolysis to extrapontine myelolysis, and later on osmotic demyelination syndrome. The basic pathological mechanism is there is rapid, if you correct the sodium very rapidly in case of chronic hyponatremia, which leads to rapid increase in the plasma osmolality. This leads to shift of water from intracellular to extracellular space. Now this will lead to breakdown of blood-brain barrier, exposure of glial cell to cytokines, complement in mediated injury, axonal injury, cellular ATP depletion. Ultimately, they all lead to induction of apoptosis and osmotic demyelination. There are specific risk factors for osmotic demyelination. The risk factors include the chronic alcoholic patients, chronically malnourished patients, the advanced liver disease patient, or serum sodium level less than 105 milligrams per liter, the chronic hyponatremia or hyponatremia that is associated with hypokalemia. All these factors are associated with high chance of development of osmotic demyelination syndrome. There are various kind of symptoms that can occur with osmotic demyelination, but classical symptoms that is described in case of frontal myelinolysis is locked-in syndrome. Here the patient is paraplegic, but because the pons level, there is a myelinolysis at the level of pons, only possible movement is vertical eye movement. Patient can close or open eye or else nothing, no movement can be done. So it is one kind of vegetative state. Otherwise, paresis, dysarthria, dysphagia, pupillary, ocular motility disorder, or loss of reflexes, all kind of symptoms can be there with pontine myelinolysis. The extrapontine myelinolysis depend on the site, symptoms depend on the site. If there is is near to the basal ganglia or around that, the movement disorders are common. Like akinetic rigid symptoms can be there, tremors can be there, choreoathetoid movement, dystonia, myoclonus, gait disturbances, ataxia, all that can be pretty much common in case of extrapontine myelinolysis that is near to what we call as basal ganglia. Or if there is more vertical side is there, then neurobehavioral, more frontal side is there, then neurobehavioral or general symptoms can be common like encephalopathy or epileptic seizure or mutism or catatonia, depression, frontal lobe disinhibition syndrome, emotional instability, primitive reflexes are all common in case of EPM or extrapontine myelinolysis that is nearer to cortex. These are the two interesting MRI. The first one is clearly telling that there is a myelinolysis or CPM at the level of dorsal pons. Well, second one is demonstrating the extrapontine myelinolysis. Now, the MRI can definitely or easily identify this myelinolysis, but trick here is that these lesions sometimes they don't develop up to the 48 hours. So lesion can be detected on MRI, but it may take up to the 4 weeks. Lesion appears from the 48 hours to the 4 weeks. So initial negative MRI does not rule out ODS. You have to get the report after say neuroradiological after and neurophysician opinion for around 2 weeks or 3 weeks duration. So take home messages for hyponatremia is that treatment the symptoms and severity of hyponatremia always depend on the rate of development of hyponatremia, how fast the hyponatremia has developed. If it is acute hyponatremia less than 48 hours, there will be always more severity and more symptoms. The symptoms and severity also depend on the magnitude of hyponatremia. That is, what is the serum sodium level? If it is less than 125 or 120, the severity of symptom level will be more. 3% sodium, 3% NaCl is indicated in case of moderate to severe hyponatremia, or whenever there is a acute presentation of hyponatremia. And last is that adaptation to low sodium and low the osmotic changes gradually occurs after 48 hours. And once the brain has adapted to this chronic hyponatremia, if you correct the rapidly the sodium level, if you go for a rapid sodium correction, there are high chances of developing an ODS or osmotic demyelination syndrome. So you have to always take in this mind. Uh, I thank all of the participants, the SAMI, and all organizing faculties for this webinar for providing me this opportunity to deliver this talk. Thank you very much.
Thank you so much about the webinar topic, Doctor. It's more about, so are you not able to hear me?
Hello.
Yeah,
I think there is some issue regarding, I cannot hear this voice issue.
okay. Just a
There is
second.
one question here that recent studies suggest giving boluses of 3% of NaCl, right? So that is what guidelines tell that that was also mentioned in this presentation also that in case of severe hyponatremia and severe symptomatic hyponatremia, the recommendations are for bolus. I think it's mentioned in presentation that the 150 ml 3% saline bolus are recommended up to two times or a total of 300 ml bolus of 3% NaCl can be used in case of severe hyponatremia. And the duration, it can be given over the 20 minutes, the bolus one. I think it will take at least 20 minutes routinely. So, yes, the guideline and all studies, they recommend for bolus 3% saline in case of severe hyponatremia.
Okay, thank you, sir. And it's before we discuss, let me tell you about the next week topic, that is traumatic shock management in ER by Dr. Amareshwar Reddy from Velamal Medical College and Hospital, Madurai. And if you have any more questions, please post them in the group, in the chat box.
Yes, for TOP syndrome, most of the time it is probably a solution or what we call as glycerin that is causing what we call as hyperosmolar hyponatremia. But the guideline or the pathway remains the same. That if it is a severe or acute, if the hyponatremia is developed acutely, then you have to go for 3% NaCl. If it is not acute and it is not severe symptomatic, uh, then just wait for the solution to wash out, right? But if it is the recommendation remains same that if it is a severe and acutely developed hyponatremia after TURF, again 3% NaCl is recommended. Whole crux of matter is that whether it's acute or symptomatic or severe, you go for 3% NaCl. Otherwise, this TURF will causes hyperosmolar
Just
hyponatremia. But most of the time it is not symptomatic, then you have to just wait and watch.
I think we don't have any more questions. We can end the topic. Thank you so much for joining us, Dr. Mehul.